everyone, I'm Ed Highland, and this is the Big Ideas Theater at AARC. I'm joined now by Jessica Schweller, who is with The Ohio State University Lung and Sleep Disorder Center. Jessica,
yes.
Thanks so much for coming by once again.
Thank you.
Good
yes,
to see you
thank
again.
you for having me
again. It's been a couple of years since the last time we chatted. We're going to talk about bariatric population, sleep disorder, breathing management. First, if you would, what is the issue there? Why is it important to have a different and better understanding of these bariatric patients?
Well, a lot of these patients come in, Ed, and they actually have no symptoms at all. They are coming in because it's a check mark on their box to get their surgery. And so when they come to see us, a lot of times they're just sitting there just talking to you about how their sleep goes. And when we diagnose them with sleep apnea, they're kind of shocked. They don't realize that this was something that they've had kind of underlying. And it's about 90% of patients with bariatric surgery will have sleep apnea as well. They also come in and they have high CO2 levels, which, as you know, as a respiratory therapist, that's one of the big things that we have to worry about with respiratory failure. It can complicate, their stay in the hospital, it can complicate their treatment modalities. We got to send a lot of these patients to the sleep lab because we're worried about their oxygen levels, how severe their hypoventilation might be. And so doing a home portable test, like most insurance companies want us to do, it's not as easy said and done as we'd like it to be. So.
Can you expand on that a little bit and talk a little bit more about what kind of complications and issues can arise in this population?
So with this population, a lot of them have multiple comorbidities when they're coming in already. That's why they're getting the surgery. They have uncomplicated diabetes, their hypertension's out of control. And so what can happen is that when we put them under the knife and we do this surgery, they're at risk for, blood clots. They're not very mobile. They can have a risk for an MI. Many of these patients, if we give them anesthesia or pain medication, they're not breathing as deep as we'd like it to be. And so we have that risk of having to intubate them again, put them back in the ICU. With their diabetes too, their wounds don't heal as well. So they can get a lot of wound injuries that don't heal. We can get the surgery site actually to kind of open up as well. So a lot of times their complications will make them have to stay in the hospital longer.
The line of communication must be wide open for these patients. In other words, the doctor, the people they're being referred into the facility, and you've got to know every aspect of this person, not just what you sort of see when they come and sit down in the chair.
Yeah, because I know a lot of times for the sleep clinic, we do a very comprehensive history and physical on these patients, so we at least know what we're getting ourselves into. But sometimes they don't want to go forward with a lot more of the evaluation that we want to do. And because what happens is that when we diagnose them with sleep apnea, it now kind of delays their procedure. So we have to make sure that they're getting treated appropriately, they're compliant with therapy, their oxygen levels look good, CO2 levels look good, and that they're using the machine before we clear them for surgery to make sure that we're reducing those risks.
Talk a little bit about post-surgery. What types of methodologies employed to make sure that, I guess the ultimate outcome would be they wouldn't need your services anymore. But tell us a little bit about how you go about weaning them from your treatment after the surgery.
Well, a lot of times too, what we do very upfront with these patients is make sure that they know that the expectation is that they still will probably have sleep apnea after surgery. There's about 40 to 80% resolution of sleep apnea. We always see an improvement in their sleep apnea, but many times patients might not come off of therapy. So giving them that expectation right out the door so that when they do still require therapy, they're not kind of shocked that they still have to stay on CPAP. What we usually do is many of these patients, if we can, we put them on an auto-adjusting device, either bi-level or auto CPAP, and then we start weaning the pressure range for them until we can get them to a safe range where they feel comfortable to maybe go without CPAP. What we then do is kind of keep in mind, some of their post-op, milestones, 6-month post-op goal, 1-year post-op goal. How are they doing with their weight loss management? Some patients will plateau pretty early on. Some patients don't have a lot of significant weight loss, and so what we usually do is see how they're feeling without the machine. We'll let them go 2 weeks without CPAP and see if they tolerate it okay, and if they do, then we go ahead and repeat a sleep study to see if we can see if it's gone.
How do you handle I'll say the mental side of this? Because the patient, obviously they're going in and this is potentially a life-changing type of surgery, but it is also a very life-altering type of surgery. They're going to have to completely readjust the way they feel about themselves, the way they eat. Virtually every aspect of their life is going to be changed somewhat by the surgery, and then there's the treatment aspect of it as well.
Exactly. A lot of these patients, one of their requirements too is that they undergo a psychiatric evaluation. So we've had patients get denied surgery because they didn't pass the psychiatric evaluation. And a lot of the questions that they ask during that time is, do you have a strong support system who's going to be there for you after surgery? Are you doing this for, personal gain, cosmetic reasons, or do you have the health concerns and understand what, life is going to be like when you're done with surgery? Many times these patients don't have the support system of having a gym available or, being able to access a lot of these equipment that they need or the follow-up care, but we try to make sure a lot of these patients have a good support system amongst their colleagues who have gone through this procedure. We have support groups that they go to. They have an online Facebook page that they communicate with each other through, and it gives them just that kind of, camaraderie with a lot of other people who've gone through the same thing to prevent the weight gain, prevent their health conditions from coming back, and hopefully have some support outside.
Are you getting a lot of feedback as well in terms of the research, the study? Each patient is going to be unique.
Mm-hmm.
Are you getting a lot out of it as well that helps further the program and allows you to offer perhaps even enhanced services to the next line of patients that come in?
It does. So I've been doing sleep medicine for 11 years, and actually as soon as I started working there, one of the physicians who came in started doing the bariatric population and said, I want you to work with me. So I've been working with this population pretty closely. One of the things that we have found is that, making sure that they're adherent to therapy, following the Medicare guidelines of 70% over 4 hours, really has helped reduce our post-op complication risks as well as readmission back to the hospital. And so trying to make sure that these patients know we're not just making up this number because we want them to, do a couple extra hoops to get to the surgery portion, but at least that it's going to help reduce their risk of these complications afterwards.
Great information. Jessica, thanks so much for coming by.
Thank you for having me.
And this is the Big Ideas Theater at AARC. I'm Ed Highland. Thanks for joining us.